Okay, now you're doing something called the SOFA, and this is complicated. And where it's complicated is there are whole charts with different organ failures, but you could do something at the bedside called the quick SOFA scale. And that involves three things: change in mental status, increase respiratory rate, or decrease BP. And that's the Q SOFA, and this is sepsis 3. The bottom line, you're going to recognize sepsis. Okay, someone comes in with a fever, they may have SIRS criteria, and they have a source of infection. 3, hemodynamics are abnormal, the blood pressure is low. That's septic shock. Okay, so, and amidst all this, you can risk stratify it by getting a lactate. And if the lactate's elevated, you have organ hypoperfusion generating lactic acid. Doesn't always work like that, but it usually does. So what do you do when you see a septic patient or someone you suspect is sepsis? You gotta work right away, okay? And they had these evaluations in the ER. This started, probably around a little before 2010, where they had a surviving sepsis campaign. And they wanted people in the emergency room to get these patients as soon as possible. And the idea was the quicker you give them antibiotics and fluids, the better they're going to do. And, it used to be there could be a time delay, but really with sepsis, it's a 1% per hour mortality. So the idea is you have a patient who's septic, you get them in, you get an IV in them, and you start giving them fluids. And the bottom line is lactated rigors, a balanced solution, is probably better, although you can use normal saline. And then you're going to culture them up, and you're going to give them antibiotics. Now, ideally, you want to do something called source control, okay, where you look at the source. Somebody, if it's coming from the urine, you want to look at the urine. You want to make sure they don't have a kidney stone. And if they have a kidney stone and they're septic or in septic shock, you want to put a stent in them that night or that afternoon whenever they present. Okay, if it's hepatobiliary, okay, and they have cholangitis and they have obstruction, you want to go in and do an ERCP and papillotomy right away. If it's pneumonia, you might not do a procedure, but you know what it is, and then you're going to give appropriate antibiotics. So it's source control, and you want to give antibiotics early. And if you don't know what you're treating, you're going to give them broad spectrum antibiotics. Some good gram-negative coverage, like a cefepime or a Zosyn, and probably some Vanco. Now, if you know it's the urine, then it's gram-negative coverage. And if it's, obstructing common bile duct, you're going to get anaerobic coverage. Or if it's a perforated bowel, anaerobic and gram-negative, especially gram-negative rod coverage. And you're going to give them fluids, and you're going to monitor them, and you're going to check their labs. If they're an acute kidney injury, you have to watch them. They could go into ARDS and not have pneumonia. They could go into DIC, or they could just be thrombocytopenic. You need to monitor all this stuff. And then pressors. The pressor of choice is Levofed. And what I believe is going on now, giving pressors earlier, and the idea if you pour fluids into them, it might be better to give them fluids and start pressors early and limit the amount of fluid they get. Levofed's usually the first pressor given, then vasopressin, and then possibly dopamine. If their blood pressure is really low, phenylephrine. The other thing are corticosteroids, and there are trials supporting steroids and not supporting steroids. And the most recent major papers had one study supporting it, one study non-supporting it. I think if you suspect they're in adrenal insufficiency related to the sepsis, like Waterhouse-Fredrickson or whatever, obviously you can give them steroids. But if somebody is hypotensive and they're on Levothyroxine and vasopressin and maybe another pressor, and they're still hypotensive, and you feel the hypotension secondary to sepsis, then you'll give corticosteroids. But the key point with sepsis, you have to recognize it right away. You have to look for the source, do source control, early antibiotics, and early fluids. And hopefully you'll prevent them from being in septic shock. If they're in septic shock, you have to work that much quicker. You have to get fluids in them, and you have to get the appropriate antibiotics and have them in the ICU. You know, diagnosing this, there are different algorithms. You know, people still, a lot of them talk about SIRS plus, source of infection, which is something you could look at. It's not the SOFA is what's used, and I can't regurgitate everything that's on that paper. The quick SOFA, if you have somebody with a fever and they're hypotensive and they're obtunded and they're tachypnic, you know that patient's in trouble. But usually you could recognize this with other things. And with that, I'm going to stop. Thank